So once the baby has respiratory distress and is admitted to the NICU, how do we proceed with the further management? So we should remember that RDS is an evolving disease. So the picture you see at any point in time is likely to change, both depending on the progress of the condition and the intervention that you're doing. So continuous careful evaluation at every step and timely intervention are essential. There is good evidence to support that surfactant therapy given early is better than delayed surfactant, and there is no evidence for prophylactic surfactant even in the tiny baby. So if the baby needs intubation and has respiratory distress, you obviously give surfactant, otherwise you go with the criteria. The European consensus guidelines suggest the FiO2 of 0.3 and CPAP of at least 6 centimeter of water. So once you reach a CPAP of 6 centimeter and the baby has respiratory distress, you decide early to give surfactant, and we will discuss next how to go about it. So the severity of RDS can only be determined clinically using a combination of the FiO2, which is a fraction of inspired oxygen that is needed to maintain normal saturation. This is coupled with a judgment of the work of breathing. Some babies are slightly tachypnic, they have grunting, but they are not recessing much, while the smaller premature babies recess. And the Downs and Silverman score of respiratory distress, you can refer my earlier videos on these, could guide you on the assessment of severity of respiratory distress. It's not essential to score it. The degree of aeration of the lungs on chest X-ray is important, and the PCO2 on the blood gas, especially in the babies under 28 weeks. We are more worried about hypercapnia, associated risk of IVH. So if you have arterial blood gas, it's well and good. If you have a capillary blood gas, remember that the CO2 is slightly higher on the capillary gases. You have to account for that. I've not mentioned lung ultrasound here because we are not routinely using it, though we are definitely in the process of training and starting to use it. So if you do have lung ultrasound, as you would see from my video on Dr. Pradeep Suryavanshie's lecture on lung ultrasound and its role, it can be used fairly easily, and if you want to introduce it in your unit, you can consider using it instead of the X-ray, and you might be able to score the severity on the lung ultrasound and decide on the need for surfactant based on that. So people and as well as studies are reporting that this may improve the progress. All these are variable and can be influenced by CPAP if adequate pressure is used. So once you review this, you apply the right level of CPAP, make sure the humidifier is on. Sometimes you notice that in the hurry-burry, the humidifier is left off, and remember the baby is getting cold air with a high flow through the CPAP machine, and that's not good for the lungs at all. Make sure the temperature of the baby is optimal, make sure we are not handling the baby too much, and then leave the baby calm for a period of time, half an hour, 1 hour, observe the FiO2. If there is worsening, you decide on the next step. If the pressure on CPAP is not adequate, the increased work of breathing can itself cause metabolic acidosis. So prompt action after close evaluation is needed if the CPAP is